Our first speaker is Dr. Buckley. Dr. Buckley is an orthopedic surgeon. He's an assistant clinical professor through the medical school. And Dr. Buckley did his fellowship training at the Stedman Clinic in Vail. Dr. Buckley is one of the orthopedic consults for Princeton, and he also serves on the physician chain with the U.S. Ski and Snowboard. And he's going to narrate our cadaver dissection.
So we're going to go through, kind of a foundation for today, which basically is anatomy, right? It's what when we were all in school, this is always harped on, and I feel like I always go back to that. And anytime you think about managing an injury, you think about really what's going on, it just comes back to anatomy. And so, this is, I think, really helpful for you, hopefully, to go back and look at, cadaver dissection, look at the foundation of how we take that anatomy when there's an injury, and then use that to function. And so I'm going to go through and try to highlight a number of these things that, matter clinically. And this was a dissection that one of our residents, Dr. Jomar Ari, did. So I'll have Eric kind of go through and talk about that, hopefully. Yes. All right, so we're starting kind of laterally here, and from a superficial standpoint, landmarks of the fibular head, the lateral epicondyle. This is kind of how we're going to look at a lateral dissection of the knee, patella anteriorly, so the thigh would be to the left, foot to the right. And as we kind of look at the initial skin dissection and then kind of look deeper, there's a couple hallmarks to point out. Certainly the first is kind of the biceps femoris here, and then the IT band here. IT band attaches kind of to the anterolateral aspect of the tibia on Gerdy's tubercle. And importantly, the biceps femoris is an important landmark for kind of this lateral side of the knee. For a long time, this lateral side of the knee was kind of not as well understood. Injuries were often kind of missed, and understanding the anatomy is a big part of really treating those. We will very commonly find the perineal nerve just behind and medial to the biceps femoris. So that's an important relationship for us at the time of surgery. Because that is something that, we got to find that nerve to then be able to fix and reconstruct lateral sided injuries. You can often get compression neuropathies here from kind of this sling of fascial tissue that overlies this perineal nerve right here. And so Jomar here is just kind of releasing that. But this relationship is really important. This nerve will come just behind biceps femoris. You can have kind of a snapping perineal nerve that will come over top, and that will be something that will be quite impactful for athletes. But that biceps femoris, attaching kind of the posterior lateral aspect of the fibular head, really matters. IT band attaching kind of lateral side, we reflect that up. You're going to see vastus lateralis, one of your quad muscles. And then, from a fracture care standpoint, this is an easy way that we will, get to the lateral side of the femur. Often where you're going to be putting plates, but you can see how the relationship as you come up here, a lot of times I can bother, if an athlete were to need something done laterally here, it can bother the IT band. But, this is a really nice dissection and really nice example of your LCL, your fibular collateral ligament here, okay? And so that's just deep, certainly to IT band, attaching here to the lateral epicondyle, actually just posterior and proximal to that. And then that will go and run down to the fibular head, attaches actually just kind of on this, what we call the champagne glass drop off here at the fibular head, just distal to that. So that is an important landmark. You see, I want you to see how tubular this structure is. You can often feel that if you're examining somebody and put them into figure of 4 position. It's a very kind of narrow ligament. It's very different than the MCL, which is a very broad ligament. And then deep to that and intra-articularly, we have the popliteus tendon. Okay, so this relationship is really important. Basically, anterior and distal to the LCL attachment on the femur, you have your popliteus tendon. And you can see that that's a stout structure, okay, often called the 5th ligament of the knee, even though it is a tendon, has a muscle attached to it, important with internal rotation of the knee. And so this is a really nice dissection highlighting those two things. And then if you have an LCL that is not intact, you can see kind of the gapping of the joint space there. Which, is indicative of, LCL insufficiency. So, that varus instability will often be missed and is a really important thing to identify on your exam, especially when you have a kind of cruciate or ACL type injury. So, As we go, we're going to work from lateral and then kind of around the back of the knee. And so kind of the next thing is looking at the neurovascular structures of the knee. This is kind of, again, looking at the back. You have your popliteus muscle belly coming around here. This is your LCL. So, these relationships I think are really important to highlight. They're certainly very important for us surgically as we're looking at reconstructing posterolateral corner injuries of the knee. And then we're going to talk about the neurovascular structures here posteriorly. So, from a nerve standpoint, we're going to show you proximally here, you have the sciatic nerve. I want you guys just to see how beefy this is. I mean, this is a very kind of robust nerve as it comes through the through the thigh. And then kind of we'll bifurcate here into the common peroneal nerve and then the tibial nerve. There's, this kind of branch here will happen. And then there's a couple superficial branches that will actually come back together, part of your sural nerve here, these little small guys right here. But, I think it's probably rare that we see this, right? And so part of what we wanted to do with starting off our day today is to just go through a lot of this anatomy so we can kind of then use that as a foundation for the talks later. So these are the sural nerves, the medial and lateral branches that are kind of shown there. We're going to then look at our vascular structures. So we have our popliteal artery and vein. The vein you're going to see as Tomer kind of picks this up a little bit here. That's the artery, and the vein is just it doesn't have the musculature, the actual thickness to it. Some of that's a tactile thing, but to withstand the pressure, you need thicker pipes, right? So an artery has a much more robust structure, and then that's the vein here, seen on the right, and that's a thinner walled structure. And so this is kind of your neurovascular bundle in the back of the knee. Sometimes you can get entrapment syndromes of the artery in the back of the knee, but those are relatively uncommon. And then as we kind of go around to the medial side, we're going to expose kind of the landmarks here. Certainly medial side, you're going to be looking kind of at your pes attachment, so your hamstring attachment here. Importantly, your sartorius, so that's kind of the more broad kind of attachment of your three hamstring tendons, and then your gracilis and semi-T are going to be deep to that. Your sartorius, as we talk when we're having a hamstring harvest or an ACL reconstruction, we're going to usually be incising that, and then you're going to see on the deep side of this tissue your two hamstring tendons. Typically, your semi-T is going to be a bigger one and more distal, and then gracilis is going to be a little wimpier. But as we take this sartorial fascia and then reflect that off of the tibia, you can see here gracilis and here semi-T. Okay, so those are your hamstring tendons. Often at the time of a hamstring reconstruction, we'll try to keep this kind of thick fibrous tissue intact, and it's a really robust way to add some bulk to your graft. But in contrast to your LCL, as we look at your medial collateral ligament now, I want you to see how broad this is. Okay, so this kind of will come certainly from the medial epicondyle running down. Importantly, it attaches more to the posterior aspect of the tibia than anteriorly, and it's a quite broad structure. We're really looking at the superficial MCL, which is the main kind of stabilizer to valgus instability. And as you compare the joint line, it attaches about 6 centimeters down. And this is really important for a number of reasons. Kind of frankly, from a non-athletic standpoint, when you do a total knee replacement, you're actually keeping that MCL intact, and you can do that because it attaches so far distal down the tibia. You can elevate that tissue but not destabilize the knee. Your medial patellofemoral ligament, which is kind of visualized here, preventing lateral translation of the tibia. And then we're just going to show you a couple examples of, graft harvest here. So there's been certainly a resurrection and a bigger push for the use of a quadriceps tendon graft. In many ways has a lot of advantages, less kneeling pain, certainly still a nice robust graft. It is a good thing to have in your armamentarium as an ACL surgeon. And so when we harvest that graft, you can take it all soft tissue, or you can take it with a bone block. This is kind of visualized here, taking it with a bone block. And so we'll often take usually about 9 to 10 millimeters of width of the bone, and then kind of try to aim for a triangular shape, and then take that with a kind of full width of partial thickness graft of your quadriceps. And so You know, this, honestly, when I was in fellowship, I did 0 quadriceps tendon ACL reconstructions. And right now I'd say it's about, 60-40 for me with BTB versus quad. It's been a really nice graft, and I've been very happy with it. And this is something that, especially in revision settings, if we've already been at BTB, this is a nice thing to have, and you get a nice bulky graft that's actually thicker and more collagen than a BTB, while still having a bone block to heal into the femur if you kind of take it like this. So you'll see that, this triangular shape is really what we look for when we're harvesting that. And then that part of the graft would go into the femur most typically. So you can see how kind of nice and bulky that is. In comparison to a hamstring where you kind of, you have what you have, and sometimes you harvest a hamstring tendon and you have a smaller graft. This, you can take a nice kind of bulky graft, and that's something that we can go into and talk about, a little bit later on. So next we're going to do just kind of an open anatomy here. This is just visualizing the patellar tendon, which was detached here. We're going to look at some of the intra-articular anatomy here. This cadaver specimen does have, signs of arthritis, which we're going to show you here. But I think a lot of this open anatomy is really good to highlight and certainly good to see as we then apply that to clinical, scenarios. And this is just an example of what arthritis looks like. You can see kind of grade 4 changes where you have exposed subchondral bone. The patella is the thickest cartilage in your body. And this is something that when you get down to this, layer, you have, small kind of osteophytes here. These are certainly painful. And this person certainly had a lot of, patellofemoral arthritis that we'll go over. So this is really highlighting your kind of medial side. So we talked about the superficial MCL, attaches very distal on the tibia. You do have a deep MCL, which is less important to the valgus stability of your knee. Importantly, people who have injuries to the MCL there's meniscal attachments to that. So that's why a lot of people have pain, especially when you palpate their meniscus. It's because there are meniscal attachments to your MCL. And then when you section your MCL, you can see the instability that will occur gapping into valgus here. So this is just kind of demonstrating that instability. All right, getting to the money here. So we have certainly, your anterior cruciate ligament here, which is kind of the thing that we're probably most commonly talking about. And my goal today is to kind of maybe highlight some things that maybe are a little less kind of common. Can you skip to 1230? So this is, your ACL here. You can kind of nicely see where it's attaching. Again, it's not straight up and down. So you're coming kind of in this direction, and down here is going to be your PL bundle, and then kind of coming up is going to be your AM bundle. And you can see the anterior horn of your lateral meniscus attaching here, which is really that orientation that we use in surgery, among a couple other things, to look at the appropriate place to put your ACL. And so, these are things that, all come down to anatomy, right? So we do, in America, there's hundreds of thousands of ACL reconstructions done every year. And this, all comes down to the anatomy, and kind of when you translate that and transect it, this is really the way that you're going to then see the translation coming anteriorly of the tibia. So this is just kind of transecting that. Any good sports medicine surgeon is going to have like a little pit in their stomach every time you do that. Why would you cut a normal ACL? I don't know. But you can see the increased rotation that's going to be there. And then I believe up next, we're going to go to the PCL. And so your PCL, it's kind of visualized here. I want you to look kind of at these. You can see the fibers of your ACL. Okay, so that is where we talked about. This is an intra-articular structure, as well as intrasynovial. So when an ACL tears, 70% of the time causes a hemarthrosis. A PCL, which is this structure attaching on the medial femoral condyle, you can see how very close to the articular margin it is. It's a very, very stout ligament, how much broader it is, and it's covered by this fat layer. So it's covered by a synovial layer. And so that basic anatomy fact is why a lower grade PCL injury doesn't need surgery. Okay, and you can see how much bigger this is. Often, because of the size of that ligament, we're actually choosing to reconstruct both bundles, both your interlateral bundle, which attaches kind of very high here at the articular margin, as well as your posterior medial bundle, because you can't do it with one tunnel. That's never been shown to matter for an ACL because the actual ligament is smaller and you can reconstruct both bundles with one tunnel. You would have to put significantly, like probably put a size 20 tunnel into your condyle if you were to try to do that with all one tunnel, your PCL. So, so again, all comes back to anatomy. That, you know, is an important distinction. And then you can kind of see a posterior drawer, the translation of the tibia here as Jomar has shown us that. You know, and then the final part of this really is your meniscus, which we're going to show you as we kind of flex the knee up here. This is going to show you kind of the relationship of your your medial and lateral meniscus. This is just showing instability. Yeah. So that's your posterior drawer, how unstable after we cut that. This is why, as you see, if you see a significant injury, you have coronal instability when you examine somebody on the field, we have to think about neurovascular injury because those can often get injured. But as you look at kind of this medial meniscus here, they're just showing us the knee, and then lateral meniscus here. The lateral meniscus is often more mobile. Okay, so it's not as kind of attached to the tibia. Your medial meniscus, both C-shaped. Your posterior horn of the medial meniscus attaches further posteriorly, pretty close to your PCL. So when we reconstruct that, we have to make sure we don't take out your medial root. And your lateral meniscus attaches more anteriorly in the posterior horn. But you can see, kind of the relationship when the condyle and the lateral meniscus are involved. That's where you often have that lateral meniscus tear. It can often be a radial tear right here in the back of your lateral meniscus that occurs at the time of an ACL reconstruction. These are basically there to provide shock absorption and distribute axial forces across the plateau. But importantly, they are secondary stabilizers to stability. Okay, and so not reconstructing a meniscus tear really affects your risk of a re-tear with an ACL reconstruction. And you can see, this relationship with a pivot shift where you'll get kind of this pinch in the back of your lateral meniscus from your lateral femoral condyle, really from a pivot shift mechanism. So, this patient has a small parabeak tear, kind of a small flap of tissue. A lot of times in the older population, that can give you a lot of mechanical symptoms. And arthroscopically, we can go in and basically trim that, and should certainly be able to help that person. I wouldn't do it with this much arthritis in it, but that's a different story. But repairing that back to a stable rim would take care of those mechanical symptoms, and certainly would be a good thing for that. So I think those are the main highlights, Eric. I think we can probably pause there.
I think we get let's just go through it.
Okay. This is the anterolateral ligament, which is part of my talk. It's more of a thickening of this fascial layer than it is like a kind of stout ligament. But something we'll talk about with rotational stability. And then, as we look at the posterior the anteromedial aspect, these are your hamstrings, and you can kind of see it when we take a graft. We're basically putting a tendon stripper that will stay and follow up the tendon as part of this, and then we'll kind of get rid of the muscular part. So that's what we're looking at a hamstring graft seen here. So that's kind of the main take homes. And then this would be usually flipped over a button, which would be done for a hamstring graft, often either in a kind of one flip or quadrupled, depending on the length and the size you need. So this person actually this would be a very nice graft. The problem is you can't pick the size of your hamstring. So sometimes you take the graft and you end up with a flipped over, 7, and you have to do some tricks to make that thicker because we know a 7 isn't going to hold up when you look at the actual size and risk of re-injury for an ACL. So those are the main highlights. So any questions at all? Hopefully that was kind of helpful as a foundation for our day. And we'll go from there.
Thank you.